Hello. In this screencast, I'll be talking about chronic pancreatitis. This will be part 3 in an approach to vomiting and abdominal pain. So, we've already established that significant but poorly localized abdominal pain could be the result of two types of pathologies. One is intraperitoneal pathologies that are either chronic, resulting in an expansion of the sensory receptive zone within the abdominal neurological system, or they could be multifocal, involving different parts of the gastrointestinal tract or various organs within the GI tract. Similarly, the pathologies could be retroperitoneal, and we call those pathologies using a mnemonic that is CRE. Okay, so these were the intraperitoneal pathologies that were likely to cause significant but often poorly localized abdominal pain. I group them as has been the case in this series as those likely to be associated with vomiting and those without vomiting. So we've covered functional causes in detail. We'll discuss peptic ulcer disease in the subsequent videos in this series along with gastritis. As I've discussed previously, the inflammatory bowel disease, celiac disease, and small intestinal bacterial overgrowth will be discussed under approach to chronic diarrhea, which is an upcoming series. And mesenteric or rather vascular disorders of the GI tract will be discussed in this series. So, moving ahead, these were the other retroperitoneal causes that we had gleaned from our diagnostic framework. So, in that, prominently featured here is chronic pancreatitis. So, these the subsequent few videos in these series, around 4 of them, are going to be dedicated to the diagnosis, clinical features, and pathophysiology of chronic pancreatitis, and then the utility of imaging in chronic pancreatitis, which is itself quite an extensive topic. So, we'll not be covering endometriosis and primary sclerosing cholangitis naturally in this series. Retroperitoneal fibrosis and aortic aneurysms will be covered in subsequent videos in this series. Okay, so I'll be discussing the following causes of significant but poorly localized abdominal pain in this section. So the first will be I'll be discussing propulsive disorders of the GI tract, excluding the esophagus, because that will be covered under dysphagia, approach to dysphagia. Vascular disorders like chronic mesenteric ischemia, chronic pancreatitis, retroperitoneal fibrosis, and abdominal aortic aneurysms. So here we'll first train our eyes to chronic pancreatitis itself, and because it is often an under it's a cause of abdominal pain that is often underdiagnosed and can go under the radar for a long time. So in this particular screencast, we'll be talking about the following topics. We'll try to understand the mechanisms that underlie the development of routine run-of-the-mill chronic pancreatitis. We'll talk about the Sentinel acute pancreatic event hypothesis. We'll review the etiologies that lead to chronic pancreatitis, and then we'll classify them based on the TIGAR-O classification scheme. We'll understand the various forms of monogenic genetic chronic pancreatitis. We'll describe the different forms of autoimmune pancreatitis, review the pathogenesis of type 1 autoimmune pancreatitis, which is also called IgG4 related disease associated pancreatitis. We'll describe the clinical features in which autoimmune pancreatitis is, clinical settings that lead to a diagnosis of autoimmune pancreatitis. And then finally, we'll try to differentiate between type 1 and type 2 autoimmune pancreatitis clearly. Okay, so jumping right into it. Chronic pancreatitis, the sentinel acute pancreatic event hypothesis. So there are basically 3 steps that have been hypothesized to occur. The first is there is a sentinel or a initial acute pancreatitis, followed by something called the intermediate stage where it does not resolve completely, and finally that leads to patchy fibrosis and subsequent exocrine and endocrine dysfunction within the pancreas. So the molecular mechanisms underlying this are essentially that damage to the pancreas during acute pancreatitis causes release of enzymes, particularly certain matrix metalloproteinases. I've used the acronym MMP for that. That results in your run-of-the-mill chronic acute pancreatitis. Then recurrent and or persistent inflammation occurs within the pancreas because of its own enzyme production and the proteolytic enzymes that it naturally produces, with secondary activation of the innate immune system and production of interleukin 1 beta, interleukin 6, and TNF alpha. This secondarily activates your pancreatic stellate cells, which essentially start the process of inducing fibrosis. This can present as either acute pancreatitis, recurrent acute pancreatitis, or subclinical persistent pancreatitis, which is, as by definition, asymptomatic. However, the patient's enzymes may be borderline elevated. Then these stellate cells develop autocrine, that is, they themselves produce TGF beta and express the receptor for TGF beta, that is TGF beta receptor 1, resulting in their subsequent conversion into what are called myofibroblastic cells. So those cells essentially cause a replacement of the normal pancreatic parenchyma with fibrosis, that is diffuse collagen type 1 and 3 deposition, and that causes secondary loss. The loss of parenchyma causes secondary endocrine and exocrine pancreatic insufficiency. So the important thing to note here is that such fibrosis is patchy. Second, the pancreatic stellate cells convert into myofibroblasts. So as the name would suggest, they have a myo component to them. That is, they also express actin and myosin filaments within the cytoplasm and cause contraction of the parenchyma. So the parenchyma actually contracts into itself, resulting in two things. That is a reduction in the thickness of the parenchyma of the pancreas, the actual parenchyma, and a dilatation of the pancreatic duct, both of which, as we'll see in the next video, are characteristic of imaging findings of chronic pancreatitis. Okay, now once you have a patient with suspected or confirmed chronic pancreatitis, a standard classification schema is used to assess causes. The acronym used is TIGAR-O. So T stands for toxic, which includes toxins such as drugs and metabolites. So metabolites include three things, and this is very important: uremia, calcium, hypercalcemia, and triglycerides. As we've seen with acute pancreatitis, the hypertriglyceridemia and hypercalcemia cause metabolic dysfunction within pancreatic cells themselves, resulting in premature intracellular pancreatic enzyme activation, resulting in damage to the cells themselves and then therefore the parenchyma. Idiopathic naturally is idiopathic, although I'm not very fond of the term. Or genetic we'll just come to. Then we have autoimmune pancreatitis, which is divided into type 1 and type 2. Type 1 is IgG4 related autoimmune pancreatitis. Then we have recurrent acute pancreatitis, particularly in the setting of radiation and vascular insufficiency. Then we have obstructive pancreatitis, which often is due to a significant obstruction that does not, anatomical obstruction that does not get relieved on its own. So this can include congenital abnormality of the pancreatic duct called pancreatic divisum, where the accessory duct and the primary duct remain separated from each other, and as a result, the main pancreatic duct actually opens at the minor papilla within the second part of the duodenum, resulting in increased pressures and a smaller opening within of the duct into the duodenum, resulting in increased pressures within the duct. Then we have anything around the ampulla that can cause abnormalities, like a periampullary wall cyst, and finally we could have abnormalities within the pancreas, the biliary duct, which runs along with the main pancreatic duct within the within the distal course of the main pancreatic duct within the parenchyma of the pancreas. Now, when it comes to genetic causes, these are the genes that and the pathomechanisms that underline such genetic pancreatitis, and these disorders have a very well described and often predictable clinical course. So we'll just go over that first. The first gene that can have a mutation in it is called SPINK1. SPINK1 actually encodes for a serine protease inhibitor Casal type 1. Okay, and this is the primary protease inhibitor that prevents excessive runaway activation of trypsin within the pancreatic parenchyma. So that if it is defective, trypsinogen gets converted automatically to trypsin, and that then causes degradation of the proteins within the pancreas. So the most common mutation is what is called N34S, and clinically it just presents as chronic pancreatitis. We'll see there is a classical cause of this kind of pancreatitis. Similarly, the second gene that can be affected is a gene called PRSS1, which causes an autosomal dominant form of hereditary pancreatitis. The mutations primarily affect two codons, codon number 29 and 122, which basically corresponds to exon 2 and 3 in the gene respectively. These are just some facts that are routinely asked in entrance exams. Finally, exon 3 mutation substitutes the normal arginine that is located at codon 122 with a non-basic amino acid. So most commonly such a non-basic amino acid is histidine. So what ends up happening is that the loss of the positively charged tail of arginine, that is because the arginine has been replaced by histidine, results in an alteration in this particular domain of the final protein that is synthesized. And this domain is normally involved in ensuring destruction of any trypsinogen that has been prematurely activated within the pancreatic parenchyma. So PRSS1 encodes for trypsinogen. So such trypsinogen which has these mutations that either at codon 29 or 122, that tends to undergo premature intracellular activation of the enzyme of trypsinogen, conversion of trypsinogen to trypsin, resulting in severe pancreatitis. So the three most common mutations that have been described are PRSSM, R112H, which is actually at codon number 112, and N29I, which is again at codon number 29. So these are overall the second most common mutations of chronic pancreatitis described in Western populations. Naturally, the Indian population does share a significant portion of this genetic overlap. Then the next gene that is mutated is CFTR, and actually that stands for cystic fibrosis, transmembrane regulator. So this is basically an electrolyte channel that allows for sodium and potassium release into the secretions within the pancreas and other parts of the GI tract. So when that doesn't happen, the secretions within the pancreatic duct are extremely viscous and they have high viscosity. So this type of mutation can co-occur with the most common mutation, that is your SPINK1 mutation, particularly N34S mutations. And when this happens, that is when it happens in co-occurs with the SPINK1 mutation, that significantly increases the risk of developing chronic pancreatitis, because the patient then has two separate gene mutations that predispose to pancreatitis. So in heterozygotes, that is a person who has one normal CFTR and one one abnormal SPINK1 mutation, you end up having a 40% or 40 times increased risk of chronic pancreatitis. But actually in homozygotes, rather heterozygotes, where you have a mutation in SPINK1 in the one allele of SPINK1, you have a 40% increased risk of developing chronic pancreatitis, and with homozygotes you have a 900 times increased risk of developing chronic pancreatitis. Now, the other proteolytic enzyme that can be affected is chymotrypsin C. This is very similar to what happens with PRSS1 or other trypsinogen. There are no specific clinical correlates because it's a very rare form of pancreatitis. Mutations in the calcium sensing receptor CASR can cause loss of function of the receptor, again causing hypercalcemia and then secondary calcium mediated metabolic dysfunction within the pancreatic cells. And this is naturally associated with familial hypocalciuric hypercalcemia. The serum calcium levels are increased and urinary loss is decreased. Finally, we have MCP1, which is actually macrophage chemoattractant protein 1. This essentially increases the macrophage influx into the pancreas, resulting in a pronounced inflammatory response to normal pancreatic enzyme activation. So low level pancreatic inflammation is present in everybody, and we'll see that is the background in which autoimmune pancreatitis also develops. So the mutation that most commonly affects this gene is the 2518G mutation. So basically, autosomal dominant PRSS1 related hereditary pancreatitis presents in a very characteristic manner. It causes frequent episodes of acute pancreatitis. The patients frequently develop all clinical features attributable to chronic pancreatitis, such as diabetes due to endocrine insufficiency, steatorrhea due to pancreatic exocrine insufficiency, and imaging often relieves a calcified pancreas. And as a result of this, the early development of chronic pancreatitis and the ongoing inflammation there, these patients also have an increased risk of pancreatic cancer that is higher than other forms of chronic pancreatitis. The cumulative risk is around 10%. So these people usually by the age of 10 years, that is in childhood, develop abdominal pain, which may be recurrent or persistent. Then by the age of 29 years, they develop steatorrhea due to exocrine insufficiency. In their late 30s, that is by the age of 38, these are median ages, they develop endocrine insufficiency, that is diabetes, and finally they develop by around age 55, they end up developing pancreatic carcinoma. So as you can see, it is a gradual but progressive progression, and as is with the case of most autoimmune pancreatitis or most pancreatitis excluding autoimmune pancreatitis, the initial presentation is always abdominal pain, followed by exocrine insufficiency, followed by endocrine insufficiency, followed by the development of long-term complications. So in the steatorrhea that develops in chronic pancreatitis, it is commonly associated with abdominal pain. So like I said, abdominal pain typically at least coexists or often predates the development of steatorrhea. The marker for steatorrhea naturally is fecal elastase more than 100 microgram per gram of dry weight of stool, and that is how we diagnose steatorrhea. And we'll come to other situations in which steatorrhea can develop in cases of chronic diarrhea and an approach to chronic diarrhea. Okay, so coming to autoimmune pancreatitis, and this is the portion of pancreatitis or the section of pancreatitis that I am most interested in. So there are some very typical characteristics of autoimmune pancreatitis that have been known for a very long time. Autoimmune pancreatitis is associated with, epidemiologically associated with 4 diseases: primary sclerosing cholangitis, actually technically now IgG4 related sclerosing cholangitis, ulcerative colitis, which we'll see correlates with type 2 autoimmune pancreatitis, and 2 systemic autoimmune rheumatic diseases, that is rheumatoid arthritis and Sjogren's syndrome. Sjogren's because there is an anti-epithelial immune response. So this is one thing that we need to know. Second thing is, naturally, because it is associated with autoimmune diseases, there is an increase in ANA titers and there is an increase in RF. But now we know that type 1 is also associated with increase in IgG4 antibody serum titers. The presentation of autoimmune pancreatitis is usually very mild. Different literature quotes slightly different things depending on what is the proportion of type 1 versus type 2 autoimmune pancreatitis. But overall, the most common presentation is an asymptomatic patient who has been incidentally detected to have pancreatic involvement, followed by obstructive jaundice. And we'll see this is because of mass-like pseudotumor formation in type 1 autoimmune pancreatitis. The relatively uncommon presentation is actually abdominal pain, and even when present, it is usually very mild. So, a patient with pancreatitis or a patient with very significant abdominal pain is actually very unlikely to have autoimmune pancreatitis. Now, 25% of patients actually develop pseudotumors, as I've discussed, and that is why they develop obstructive jaundice, because those pseudotumors tend to, change the shape and of the main pancreatic duct and the common bile duct, and that tends to create issues in the drainage of the bile as well as the pancreatic secretions. So, the pathogenesis of IgG4 related autoimmune pancreatitis, that is type 1 autoimmune pancreatitis, is rather interesting, and it is I will be discussing this again under the general discussion on IgG4 related disease. This is the archetype or the disease that defines the disorders of immune resolution. So as we will see, and I have alluded to previously as well, the immune response is very tightly orchestrated, and it is bookended at the end by a proper proper coordinated withdrawal, which is what we call immune resolution. So during immune resolution, certain things do not happen. For example, reactivation of the immune response does not happen. Similarly, the activation of the adaptive immune response, particularly T cell response due to antigen antibody, due to antigen presenting cells showing new antigens to for T cells, does not happen. That is primarily because the antigen presenting cells usually don't have any new antigens at the end of an immune response to show. B, the T cells themselves are no longer responsive to such an activation, because essentially they have downregulated the expression of certain ion channels that are present at the immune synapses that form between T cells and antigen presenting cells. For example, the potassium channel, your KV 3.1. So we'll talk about that in detail, at molecular detail, in under IgG4 related disease. But for now, I'll just describe the cellular processes that occur. So normally antigen presentation doesn't occur, as I said, at the end of an immune response, and if it does occur, T cells are not responsive to such a signal. So however, in IgG4 related disease, what ends up happening is that T cells get abnormally activated at the end of an immune response, when they should not be activated. So in IgG4 related disease, T cells that were autoreactive are presented self-antigen. So this is a antigen presenting cell presenting a self-antigen to a autoreactive T cell. Okay, this is because of a genetic predisposition to this happening, because of specific HLA-DR-B1 haplotypes that these patients have. Now, what ends up happening is, because this kind of T cell activation is occurring in the general milieu of immune resolution, the T cells don't get activated along normal T cell activation pathways. So these T cells actually develop a very abnormal phenotype. They start overexpressing 2B4, which is a co-stimulatory molecule, CD97, and TBET or TBX21, which is a Th1 polarization master transcription factor, but simultaneously decrease their expression of the co-stimulatory molecules to CD27, CD28, and CCR7. So as a result of that, they convert into a very abnormal type of T cell, three very abnormal types of T cells. The first being something called a CD4 plus cytotoxic T cell, which has been termed the THPOK, T helper POK cell. So this is the THPOK cell. Then these cells are very abnormal, and they produce two types of molecules that are out of place in this particular stage of the immune response. So they produce granzymes and perforins, which causes local damage and perpetuates inflammation. And they also produce interleukin 1 beta and interferon gamma, which are obviously pro-inflammatory, and TGF beta, which is pro-fibrotic. Okay, so TGF beta would continue the process of inducing fibrosis at this stage of immune resolution, which would be technically normal, but it would be in excess of what would be expected. Now, as a result of that, they develop a very odd type of inflammation called inflammatory fibrosis. Such cytokine production is naturally also assisted by antigen presenting cells and other and all antigen presenting cells within the pancreas, like your plasmacytoid dendritic cells and your tissue resident macrophages, infiltrating macrophages, as well as B cells. Okay, so that ends up causing a very significant inflammation and fibrosis, and we'll see this results in a very typical tissue architecture when you look at it under the microscope. Now, the other two cell types that are produced are T helper type 2, because Th2 cells are naturally produced during every immune response resolution, and a T follicular helper type 2 cell. So T helper, 240 follicular helper type 2 cells. So both of these cells, function in concert to cause B cell class switching. Essentially, they move to the draining lymph node around the pancreas, and actually those lymph nodes would be activated and slightly larger. They cause the B cells in that lymph node to class switch from the normal class switching processes from IgM to IgG1 and IgG3. Instead, they class switch to IgG4, and that is where the problem gets prolonged. However, importantly, this results in increased serum IgG4 levels, but the IgG4, the immunoglobulin IgG4 subtype is actually not pathogenic in most clinical manifestations of IgG4 related disease. It is actually this process that is causing the tissue damage in IgG4 related disease. Now, the antigen presenting cells also produce interleukin 4, which perpetuates the formation of type Th2 and T follicular helper type 2 cells. And the production of interleukin 4, interleukin 5, and interleukin 13 by these Th2 cells subsequently causes atopic manifestations, which are present in around 40% of patients with IgG4 related disease. Again, because Th2 polarization and immune resolution usually co-occur with each other. So, okay. Now, finally, the B cells, they have two very important roles that they play in immunopathogenesis of IgG4 related disease. One is they add to the cytokine production, because these are, like I said, these are the one of these types of antigen presenting cells that are present within the pancreas, and they actually present antigens to the THPOK cells, thus maintaining populations of THPOK cells. And now what ends up happening is that the THPOK cells, the antigen presenting cells, including your B cells, all produce interleukin 1 beta, TGF beta, as well as interferon gamma, resulting in a very odd type of tissue fibrosis, which we'll just describe. Now, an interesting finding that you normally have is that T follicular helper cells that cause IgG1 to or IgM to IgG4 class switching typically are present in the periphery of the germinal center, and these are specifically capable of behaving as antigen presenting cells to support T follicular helper type 2 cells as well as T follicular helper type 17 cells. This is just probably seen only in physiology, but may also have a role in the pathogenesis of IgG4 related disease. So what ends up happening is that there is because of the inflammation, that is interleukin 1 beta production that is happening because of these three cell types, we end up having extracellular matrix breakdown. So breakdown of extracellular matrix in any tissue also always does two things. One is it releases autoantigens that are present, that have been embedded within the extracellular matrix and the cells that were there within the extracellular matrix. These autoantigens are the autoantigens that were being presented by your antigen presenting cells to THPOK cells, most of those antigen presenting cells being B cells. These THPOK cells then cause more local inflammation, which causes further extracellular matrix breakdown. So this extracellular matrix breakdown may be initiated by just the low level inflammation that occurs in any normal pancreas, but would be self-limited in most people, except for people who have the ability to develop immune responses to these specific pancreatic autoantigens. Okay, now when you have extracellular matrix breakdown and you have your THPOK cells producing TGF beta, you have TGF beta released into the extracellular space. That results in a very characteristic type of fibrosis. Essentially, it's like with inflammation, you wipe out the extracellular matrix and then you fill it up with junk extracellular matrix. So there is almost a confluent, wavy, storiform or interweaving form of fibrosis that develops. This is otherwise still fibrosis, but importantly, because it's storified fibrosis, the number of myofibroblasts that are present within this set of fibrosis are very minimal. Local inflammation also causes endothelial activation, which under the microscope looks like something called obliterative phlebitis. So phlebitis because the endothelial cells show blebbing and inflammatory changes, and it is obliterative because there's so much fibrosis around that the endothelial lumen is getting distorted. So naturally, IgG4 related disease and IgG4 related disease associated autoimmune pancreatitis is thus characterized by local inflammation, not systemic inflammation, storiform fibrosis, which I have described just now, obliterative granulitis, and often extensive lymphoid plus plasma cell infiltration, plus or minus atopic features, which includes increase in serum immunoglobulin E levels as well as or eosinophils. But there is no systemic inflammation, as the entire process coincides with immune resolution. So the interleukin 10 and IL-33 levels are actually very high, and as a result, there is no production of interleukin 6 and TNF alpha in significant quantities. So as a result of that, the patient does not have any features of innate immune activation. So this is interesting because clinically the finding of fever or the finding of hepatosplenomegaly, significant splenomegaly, significantly elevated inflammatory markers outside of the fibrotic manifestations of IgG4 related disease, and inflammatory arthritis is extremely odd in IgG4 related disease and requires an alternate explanation. It doesn't correlate with the diagnosis of IgG4 related disease and must be explained by an alternative explanation if it is truly IgG4 related disease. Often it results in a reassessment of the diagnosis. Now, coming to the last part of the discussion, we have autoimmune pancreatitis, which can be divided into clinically into type 1 and type 2. So these subdivisions are actually based on the expected histopath before the histopathology has been done. With type 1, we expect the histopathology to be that of IgG4 related disease, and with type 2, we expect the histopath to be that of something known as duct-centric pancreatitis, where you have neutrophils infiltrating into the ductular epithelium of the pancreas. We'll talk more about this in the subsequent screencasts in this particular sub-series. So type 1 autoimmune pancreatitis is also called IgG4 related pancreatitis. Type 2 is called idiopathic duct-centric pancreatitis. It shouldn't be called idiopathic. The prevalence rates of type 1 autoimmune pancreatitis are 10 per lakh population, which itself is quite low, and the incidence is 1 to 3 per lakh population, whereas that of type 2 is about 1 to 4 per lakh population. So as a result of this, what ends up happening is that around 60 to 70% of all autoimmune pancreatitis is actually type 1, but a significant minority is still type 2. Patients with type 1 have a male predominance, so there is a male to female ratio of 2.94:1. Type 2 is actually equally distributed among males and females. Type 1 typically occurs in Asian populations, East Asian in particular, but even Indian. Type 2 is more likely to occur in European patients. Type 1 typically occurs in older people. As I've discussed, it is a disorder of abnormal immune resolution, and such abnormalities are characteristic of an aging immune system. The median age of presentation being around 64.8 years at diagnosis. Type 2 is typically occurs in younger patients. Both diseases don't have significant family history, and the pathogenesis of type 1, as I've discussed, is impaired immune resolution. The pathogenesis of type 2 is an actual autoimmune anti-epithelial response mediated by Th17 cells and neutrophils. Okay, this is in contradistinction to what happens in Sjogren's syndrome. The clinical presentation is very characteristic in type 1. As I've said, the literature varies, but most patients are predominantly asymptomatic, but some literature says that obstructive jaundice is the most common presentation. So out of all of the patients who are symptomatic, most commonly it is obstructive jaundice. Abdominal pain with malaise, that is constitutional symptoms, is there in around 40% of cases, but prominent constitutional symptoms should always make you think of an alternate diagnosis. And acute pancreatitis is a relatively uncommon presentation of type 1 autoimmune pancreatitis. On the other hand, type 2 pancreatitis typically presents with abdominal pain due to acute pancreatitis. The presentation is that of acute pancreatitis. Other presentations of type 1 autoimmune pancreatitis are similar to those of IgG4 related disease. So patients can have unintentional weight loss, which makes the exclusion of a malignancy even more prudent. They can develop exocrine insufficiency, and they can develop diabetes mellitus. So of the exocrine and endocrine insufficiency, we saw that with typical chronic pancreatitis, it is endocrine insufficiency that occurs later. However, endocrine insufficiency is relatively more common with patients with IgG4 related pancreatitis, possibly because of coexisting diabetes or complications of therapy, but that also is part of the immunological process that is happening and the loss of pancreatic tissue that occurs. So diabetes mellitus is present in about 1/3 of patients even prior to initiation of steroids. It develops along with initiation of steroids in 52% of patients, and it can occur after steroid initiation in around 15% of cases. But over a long period of time, such steroid initiation and preservation of pancreatic tissue actually stabilizes their glucose, serum glucose levels, and therefore, in a way, steroids initially cause dysglycemia, but eventually allow for control of blood sugars. Type 2 very rarely actually presents with obstructive jaundice or exocrine insufficiency or endocrine insufficiency in the form of diabetes mellitus. So the type 2 is the one that presents with acute pancreatitis. Type 1 actually is usually asymptomatic when symptomatic presents with obstructive jaundice, much more commonly than abdominal pain. And the abdominal pain when present is mild. Okay. Now, the associations are very typical. So type 1 is associated with IgG4 related disease, no doubts about it. Type 2 is not. Okay. Type 1 can be associated with inflammatory bowel disease, but that is uncommon. Okay. Less than 5% of cases. Type 2 is not associated with IgG4 related disease, but it is very strongly associated with inflammatory bowel disease. The presentation in some literature, it is there in up to 30% of cases, but as per Harrison, it is 10 to 20% cases. So that's what we'll go with. IgG4 related IgG4 levels are elevated in type 1 in autoimmune pancreatitis in 67% of cases, but can also be elevated in type 2, although it is in a sizable minority, that is 25% of cases. So up to 50% of type 1 autoimmune pancreatitis can present as an isolated pancreatic disease without any extra pancreatic involvement. So essentially, in isolation, serum IgG4 levels or lack of extra glandular involvement does not favor one type of autoimmune pancreatitis over the other. It is the sum of the clinical presentation, as always in medicine, that allows you to decide on whether it is type 1 or type 2. And even then, there is difficulty in finally assessing the possibility of type 1 versus type 2 autoimmune pancreatitis. However, one thing that does favor type 2 is coexistent inflammatory bowel disease. Actually, the most reliable differentiating factors between type 1 versus type 2 is the response to steroids. So response to steroids is actually good in both cases, but relapse rates are significantly higher in cases of type 2 autoimmune pancreatitis, type 1 autoimmune pancreatitis. Finally, it is the histological morphology, and histological morphology obviously requires you to take a biopsy specimen, which can be often very difficult with the pancreas. Now, coming to response to steroids, both types of autoimmune pancreatitis respond very well to steroid therapy. With type 1, the relapse rates are high. That is, they can be as much as 60%, and the lower range is 20%. Whereas with type 2, that doesn't recur. So it happens in less than 10% of cases. So IgG4 related autoimmune pancreatitis is what tends to relapse after steroid therapy. And there are some very specific risk factors for this. These risk factors, as always, I divide them into clinical risk factors, serological risk factors, imaging, and treatment related risk factors. In the clinical risk factors, it is in the epidemiology of the patient, it is younger IgG4 related disease patients who tend to relapse again and again, and it is multi-system IgG4 related disease that tends to relapse again and again. Similarly, for serology, higher baseline IgG4 level in serum and or higher levels after induction therapy indicate high risk of relapse. Similarly, coexistent atopy, because it just basically indicates that there is the immunopathogenesis is very florid and very active, indicates high risk of relapse. Imaging, the presence of a lot of involvement of the pancreatic tissue, that is diffuse pancreatic enlargement, and the presence of extension of that process into the common bile duct, that is presence of sclerosing cholangitis, especially in the proximal aspect of the common bile duct, increases the risk of relapse. Similarly, treatment will see the drug of choice is actually rituximab for preventing relapse. So if you have induction therapy that does not include rituximab, that is if you use methotrexate as a therapy, the relapse rates are higher. And the typical dictum is to continue steroids at low doses, that is 5 mg per day of prednisolone or equivalent, for at least 2 to 3 years. If that is not done, the relapse rates are high. So these are the risk factors in an IgG4 related autoimmune pancreatitis for relapse. Again, on biopsy, presence of eosinophils also predicts relapse. So, like I said, the recommended prednisolone dose is 5 mg per day for 2 to 3 years or equivalent. So, this brings me to the end of this screencast. We've understood the mechanisms underlying the development of routine chronic pancreatitis. We've understood the sentinel acute pancreatic event hypothesis. We've reviewed the etiologies that lead to chronic pancreatitis and used the mnemonic to remember them, that is TIGAR-O. We've talked about the various forms of monogenic chronic pancreatitis and their natural history and the genetic abnormalities that result in them. We've talked about the different forms of acute pancreatitis, understood the pathogenesis of type 1 autoimmune pancreatitis at a superficial level, and we've described the clinical settings in which this autoimmune pancreatitis is to be suspected routinely. We've also differentiated between type 1 and type 2 autoimmune pancreatitis at a clinical level. We'll talk about histopathological differentiation in the third screencast of this subseries on an approach to significant but poorly localized abdominal pain without vomiting. So thank you for watching, and I'll see you in the next video.